Hi everyone, I want to talk about aspirin. This is going to be an interesting and familiar topic because we are all familiar with aspirin. The mechanism of action of aspirin is that of irreversibly inhibiting both cyclooxygenase 1 and cyclooxygenase 2. Let me repeat. Aspirin irreversibly inhibits both cyclooxygenase 1 and cyclooxygenase 2. It prevents prostaglandin production, and when that happens, that will lead to prevention of gastric protection, vascular hemostasis, platelet aggregation, and kidney function, all under cyclooxygenase 1. Cyclooxygenase 2 is responsible for inflammatory processes secondary to exposure to growth factors, cytokines, or other mediators of inflammation. So when cyclooxygenase 1 is blocked, I've just mentioned everything that will happen. When cyclooxygenase 2 is blocked, the inflammatory process is blocked. The efficiency of serine 530 is trans-acetylated by aspirin, and that will result in the inhibition. And that trans-acetylation is about 1 for cyclooxygenase 1 and requires 10 folds to do the same inhibition with cyclooxygenase 2. In other words, you need 1:1 ratio of aspirin to block cyclooxygenase 1 using 530 trans-acetylation, but you require 10 folds of the same quantity of aspirin to do the same while trying to block cyclooxygenase 2. In other words, this will give you a clue why very high doses are required for inflammatory process compared to the low dosage that will be required for antithrombotic effect. Do I need to repeat that? When cyclooxygenase 1 is to be blocked, you need lower dosage of aspirin. But when you need to block cyclooxygenase 2, you need 10 folds of the dosage you need for antithrombotic effect. And I will give an example here. To my grandfather and grandmother that are on aspirin for prevention of thrombotic disorders, the heart and everything, they are just on 81 milligram of aspirin once daily. Okay? The same aspirin for my grandfather or grandmother who is having rheumatoid arthritis, it's not going to be 81 milligram once daily. You are going for 650 milligram twice or 3 times daily, and even some people 4 times daily. Why? The amount required to prevent inflammatory process by blocking cyclooxygenase 2 is 10 folds higher than the amount required to block cyclooxygenase 1 responsible for thrombotic process. The biochemical pathway here is just that the cell membrane has phospholipid bilayer, and cytosolic phospholipase A2 catalyzes the conversion of the phospholipid to arachidonic acid. The arachidonic acid will give rise to prostaglandin 2 with the help of cyclooxygenase 1, cyclooxygenase 2, prostaglandin H synthase. So when prostaglandin H2 will give rise to prostaglandin D, we need prostaglandin 2 synthase. When prostaglandin E2 will be produced, we need prostaglandin E2 isomerases to act. When prostaglandin F2 will be produced, we need prostaglandin F2 synthase to act. When prostaglandin I2 will be produced, we need prostaglandin I2 synthase to act. Now, for thrombosin, I will soon talk about thrombosin. We need thrombosin A2 synthase to act, to catalyze that process. Prostaglandins generally, they are not secreted by the glands. They are formed at the sites of injury or infection requiring them. They cause pain, they cause inflammation, and they cause fever. They are used in cervical ripening in obstetrics and gynecology, some cytotech. They increase intrauterine contraction. Cytotech and everything like cervical ripening is a different topic, and I will not go into that here. They maintain feeder flow. Hence, you need to block prostaglandin in patent ductus arteriosus. So when there is patent ductus arteriosus, mostly in preterm babies, you are in trouble because you want to close that ductus arteriosus that is patent. Prostaglandin is helping the ductus arteriosus to remain patent. Hence, you block that using antiprostaglandin medication. We don't use aspirin to do that readily. We use indomethacin. Indomethacin will do that for those neonatologists who want to close the ductus arteriosus that is patent. But this is the background of it, that the prostaglandin is responsible for maintaining the feeder flow by keeping the ductus arteriosus open. And when you block that prostaglandin using indomethacin, is likely you are going to achieve your aim. Prostaglandin E, also uterine, and prostaglandin F for cervical ripening, contraction and relaxation of smooth muscles, constriction and dilatation of blood vessels, controls blood pressure, and modulation of inflammation. Thrombosin A2. Thrombosin A2 is from prostaglandin H2. It is a vasoconstrictor produced by activated platelets and has prothrombotic properties. It stimulates activation of new platelets and aggregates more platelets and causes thrombosis. You can see when that pathway is blocked by aspirin, so thrombosin A2 is blocked, and that's why it's used as antithrombotic agent. For pain, for fever, and for inflammatory purposes, we use aspirin. Like I've just explained, that prostaglandin will cause pain, fever, and inflammation. So you block cyclooxygenase 2 for inflammatory purposes, then you use that in treating rheumatoid arthritis, giant cell arthritis, Kawasaki disease, antiplatelets, or antithrombotic purposes. Low dose of aspirin will serve as antithrombotic, like I've just explained, while high dose will serve as analgesic and antipyretic. Okay, because you want to block the pain and block the fever, so you need a dose that is higher than that of antithrombotic effects as your goal. But when your goal is for anti-inflammatory purpose, then you need very high dosage. I've explained why that. The side effects. There's possibility of acute renal failure secondary to renal vasoconstriction and acute interstitial nephritis. Congestive cardiac failure can become worse enough, and there might be mild rise in blood pressure. Don't use aspirin in children. Why? Possibility of Rett syndrome. I will not go into details of that right now. I'll make a separate presentation of Rett syndrome soon. There's possibility of allergic reaction, and you need to ask that before placing my uncle on aspirin. Gastric ulceration with abdominal pain because the protection is ward off when we are using antiprostaglandin or inhibiting the secretion of the same through aspirin. And that explains why anyone on aspirin is likely going to come down with gastric ulceration, gastric ulcer. There's possibility of increased thirst and, of course, headache. Ringing in the head, nausea, vomiting, diarrhea, confusion, lightheadedness, drowsiness, flapping of hands in elderly, and tachypnea are also possible side effects. Okay, aspirin could be in normal dosage, consume as prescribed, and you're getting results. Even when you use aspirin and you are down with gastric ulcer, there is rescue medication for that. Misoprostol will help. Now, some people, for reasons best known to them, and some actually accidentally, will consume more aspirin than required or than prescribed. And what are we going to face? One, initially, at the earlier part of it, you can have tinnitus, have hearing problem, they start hyperventilating, then they have alkalosis from hyperventilation, you have cough, wheezing from pulmonary edema, can be vomiting, and when that is a lot, they come down with dehydration and the sequelae. There could be fever, the vision could become doubled, they feel like they're fainting, the heart is having arrhythmia, and of course, like I said, respiratory alkalosis. So that is the early part of it. Consumed just few minutes or hours ago. But if no intervention, then they go down to the later presentation and they come down with drowsiness, they become confused, and they start having bizarre behavior. They won't be steady. They can go into coma, respiratory acidosis, and if nothing is done quickly, they may die from that. If it is mild, they can have deep and fast breathing, become lethargic and drowsy. If the toxicity is, say, moderate, they can have severe deep and rapid breathing. But when it is severe, maybe the amount consumed is so much and there is no intervention on time, coupled with some comorbidity, there could be convulsions, coma, and death. How do we treat anyone with toxicity? We check the airway for any foreign body or secretion and attend to that as it is appropriate, including physically removing foreign body and sanctioning any secretion. We check the breathing, what is happening to the chest region, any deformity, Is it moving with respiration? Any use of accessory muscle of respiration, flaring of alveolar nasal, and the likes. Then we check the respiratory rate. What's the pattern of respiration here? Any central cyanosis. We check the circulatory system, pulse, the blood pressure, heart rate, fluid status. Put our catheter in to no fluid in and out. Have a fluid that is appropriate for the situation at hand, and we'll go for one other thing immediately. Give activated charcoal 1 gram per kilogram per oral within 2 hours of ingestion. But this individual must be conscious and must be cooperative, or else we're going to have another problem. Then we check glucose, and we have to do one thing: alkalinization of serum with intention of urine alkalinization. Okay, while doing that, you can just give sodium bicarbonate. But by the way, before you go into that, you need to check arterial blood gases. Okay, so we'll give the sodium bicarbonate 1 to 2 milliequivalent per kilogram. May choose the strength that is available, 4.2 or 8.4% start. Then to just discuss or know the protocol in your department or your hospital. Then maintain 100 milliequivalent in 1 liter of D5 till pH is between 7.5 and 8.0. You need to check potassium level and correct as it is appropriate. When you are handling toxicity, you need to do some investigation. Find out what the serum level is. Is it greater than 2.9 millimoles per liter? Yes, we're in trouble. What is the creatinine level? Rising now? Potassium is down. Any bleeding here? Increased INR or increased PTT? What's the problem with the liver because of possibility of hepatotoxicity? And of course, that might give reason to why we're having INR and PTT rising. Increased lactate, anion gap increase, the blood glucose, and attend to as is appropriate. I've mentioned arterial blood gases before. So CT of the head because of the drowsiness. You are concerned that is this aspirin induced alone or there's something else going on. You are going to have hemodialysis in this person if the individual is unconscious, if there's pulmonary edema or cerebral edema, acute kidney injury or chronic kidney disease. Is there severe acidemia here? You've done your arterial blood gases, the pH is giving you the clue, or this person has consumed a very, very large amount of aspirin, or you've been doing everything and you're not winning, the individual is clinically deteriorating, then hemodialysis will be needed in all these scenarios. In conclusion, just use the medication as being prescribed. It is good, but can be bad. You've now watched or listening to toxicity and all the sequel. Watch out for other medications that I'll be talking about very soon. Thanks for listening to my presentation. Kindly subscribe to my channel so that you can be getting all these publications immediately they are released. Thanks. I appreciate it.